So, hello everyone. Today we'll be discussing a very important class on Wilson's disease. And if you know this chapter, Wilson's disease, most of the time in your Viva, somewhere it will come. Cirrhosis case or neurological case, they are going to ask you question for sure. If you see the MCQ pattern of NEET SS, it carries quite a good significance if you tell that the possibility is high, specifically the mutation they ask, about KF ring and percentage they ask. Those possibilities are quite high, so we should be knowing it. If we go for theory exam, sometimes neuro Wilson is a short note, treatment of Wilson disease is a short note. So it is in a way much no topic. Practical exam already I told that it is quite a worth to know. Clinical practice, yes, you will be happy when you diagnose that case. And if you want to take a one-line summary, when you get a dystonia in a young patient, think Wilson. That is a very important differential diagnosis to consider when you get a dystonia in a young patient. There can be a lot of differential diagnoses for dystonia, but one of the most common or what we should not ignore is Wilson's disease, right? Then I will say the last slide of this chapter. Only 15 slides are there, so it is not going to take much time. But the last slide of chapter carries a very important message that as an Indian we should carry, right? So we will further discuss the chapter, and this is the timeline of the disease. And I always keep telling that if you want to read a disease in a full detail, always go to the Nature disease premier. So there they actually cover everything about the disease, how it started and what is the current management. So if you get the recent Nature review article, you will be lucky enough to know everything about disease, what is there in literature. It is way extensive than Harrison, but sometimes reading table images gives us a very good idea. So if you see the history of Wilson's disease, it all started somewhere in 1700 1800, where it was very simple. Liver plus neurology was combined. This person having hepatic plus neurological disease was first described. Somewhere in 1902, this KF ring was described. Okay, the corneal deposits and all. That was the 1902. In 1912, you got the person Keiner Wilson who described 12 causes of the disease, and that's where it was decided it's a Wilson's disease. In 1913, it was established that defective copper metabolism was the reason for Wilson's disease. 1951, the first treatment for copper toxicosis was discovered, and it was BAL, correct? British anti-levisate agent. 1956, D-penicillamine was introduced for the treatment of Wilson's disease. We do not use it now. 1961, zinc salts were introduced. They are still the standard of care. 1971, first transplant was done for Wilson's disease, liver transplant. 1982, trientrin was introduced, and 1993, the genetic cause ATP7B was linked to Wilson's disease. And this is the speciality of this kind of articles. It gives us one timeline that over last 200 years what has happened to the disease, and if we know that, really it will make the difference for imagination. See, medicine, identifying disease, clinical features, everything is fun, but if you know the natural history of disease or how it has evolved, it still makes it better. So first we will go to the genetics of Wilson's disease. Very simple things, not a detailed thing, but genetic and pathogenesis, just to give us a rough idea what actually goes wrong, then we can make it correct, right? That is always aim. If we know what goes wrong, we can make it correct, right? So genetic, if you see, it is an autosomal recessive disorder with mutation in ATP7B gene, which encodes a membrane-bound copper transporting ATPase, right? So that one channel at the cell membrane is defected, which was responsible for this copper transport. Okay, that is the main problem in the Wilson's disease due to mutation. The sibling of a diagnosis patient has 1 in 4 risk of developing Wilson's disease, and a children of an affected patient has 1 in 200 risk. These are the two questions which your patient will definitely ask. Okay, so in your clinical practice, you have to respect this. You have to know this, that okay, I have disease. What is the chance my brother will have, my sister will have? So it's a 1 in 4 for a sibling. What my kids will have, 1 in 200. That's a quite a high chance. So you really have to tell, and if require, monitoring and pre-treatment. Because Wilson's disease is a highly penetrant disease. So if there is a genetic mutation, they are going to manifest. Okay, that's a very important line to remember for this disease. If they have that haplotype present, which can be done by the DNA haplotype analysis, it can really help in the treatment starting from the pre-symptomatic phase and not allowing copper to deposit in those tissue, causing all this problem, right? So that is a very important genetic advance what you and I should be aware and should be using if patient is given to us. Okay. Now why we feel that as a physician I have completed my 1 year of residency, 2 year of residency, 3 year of residency, I am not diagnosing much Wilson, because the last slide of the chapter will give you the clue. We live in India. The age of Wilson's presentation is quite early. It is more of a pediatrician domain. That's why you do not get it much. Sometimes it happens during transition, they are treating and suddenly patient age is 18 and hospital says no, you have to go to physician, not to the pediatrician. It really becomes troublesome for us because we are not that well experienced with Wilson's disease. Then we write refer to gastroenterologist, right? This is what the current practice says and it is done like that. But it is better to know an MCQ you cannot refer anyone to, right? You have to answer that. So let's go with this. So the DNA haplotype analysis will be helping to genotype a sibling of an affected patient. And why it is important, you know it, right? Because the pre-symptomatic phase treatment is going to do magic. So ATP7B mutation, autosomal recessive, 1 in 4 risk in a sibling, 1 in 200 risk in a children of the affected patient. That's a minimum memory I want to have with this chapter, right? So this is the slide, and next we are going for the pathogenesis. Now see, there's a mutation and recessive, and someone has taught me very nicely, and it really helps me. Whenever there is a deficiency of something, majority of cases are autosomal recessive. Okay, so autosomal recessive is mostly deficiency. When the gain or something is there, it is autosomal dominant or it may be autosomal recessive. But something is deficient, 99% it is recessive disorder. Okay. So ATP7B protein deficiency impairs the biliary copper excretion, right? The copper is not getting excreted through the bile. The biliary copper excretion is blocked, means they are inside the cell now, which leads to positive copper balance, hepatic copper accumulation, and copper toxicities from the oxidant damage. This is the crux, right? So that's why I'm telling that if we get the pre-symptomatic phase and we start treating and things goes well, we will not allow this copper toxicity to develop. If that does not develop, the world is really good, right? So that's a very simple thing. Due to defect in ATP7B, there will be the impaired biliary excretion, more and more copper deposition, and when accumulates, it causes oxidative damage and things goes bad. Okay. There will be defective copper incorporation into the apoceruloplasmin, which leads to excess catabolism and low blood level of the ceruloplasmin. Again, not that great test. We will come to this diagnostic test of uh, Wilson's disease, because most of the time we end up in ordering serum copper level and ceruloplasmin, telling we are screening it, right? But sometimes we do not know. It is just reflex. We have read somewhere in MCQ during our MBBS to MD, one of the senior told you send it at least, so you can tell your boss that you have at least looked at that, right? But if we know exactly what to send, the life will be quite good. Serum copper levels are usually lower than normal because of the low blood level of ceruloplasmin, which normally binds more than 90% of the serum copper. Okay, so serum copper will also be low, ceruloplasmin also will go low. As the disease progresses, non-ceruloplasmin serum copper, that is called free copper level increase, and that's a very important parameter, which results in a buildup in other parts of the body. Okay, see, if it is in circulation, ceruloplasmin is going to take care. But when free thing increases, it gets deposited in brain, causing neuropsychiatric symptom and all. There are a lot of it. It's a very wide clinical spectrum of Wilson's we'll be seeing soon. But before we go into the disease, we are realizing it's a genetic autosomal recessive disorder caused by ATP7B protein deficiency because mutation was there. That is all leading to defective excretion of copper from the cell and accumulation. The accumulation increasing, cause the oxidative damage. Especially it goes high when serum free copper value increases, which can get deposited in the brain, causing neuropsychiatric manifestation of Wilson's, right? So everything is happening. Along with that, you are getting this manifestation. This can get deposited at multiple places and cause damage, K-frame, right? So these are the parts where we have to be little careful about the things. So the clinical presentation. So typically mid to late teenage year. Now see, this is what we are reading is Harrison. This is what we are reading data of US, right? Mid to late teenager. For us, it is even earlier because mid to late teenage years, most of the time 14 years, people start shunting cases to medicine. 14 years over, now it is not pediatric. It is in different in all the hospitals, right? Some are 16, some are 18, some are 14. So in US, if that kind of fight is still going on, it will be seen by physicians only. Okay. The hepatitis cirrhosis or the hepatic decompensation can happen. In severe hepatic failure, hemolytic anemia may also develop. But it tells the young cases of cirrhosis always look for Wilson's, and that is okay. That is worth looking for. But remember, when you are telling the differential diagnosis of a 42-year-old male who is having liver disease and patient is not consuming alcohol, if you have ruled out the, or if you think that it is unlikely to be non-alcohol fatty liver disease, which is cause and most commonly undiagnosed cause, then you can start thinking other etiologies. One of them will be autoimmune hepatitis, one of them will be hemochromatosis, one of them will be Wilson. But do not go so high for Wilson in a 42-year-old male, right? We should not go. We know the natural history and wait for the last slide. I am really making it that last slide will really matter for your MCQ. It will really matter for your practice. Okay. Because someone says that Wilson is, I have ruled out, I'll be happy. Okay, you have thought of that. But did you consider it so strong, right? Sometimes when we have to balance money of patient, we have to be smart enough that what is more likely probability and what will be more cost effective investigation approach. And that's how you go for that. So if we see the neurological feature of patient, typically occur in patient in their early 20s, again this is US, so it is more earlier in India. Damage in the basal ganglia and occasionally in the pons, medulla, thalamus, cerebellum and subcortical area. So if you are now doing a good MD, you can have the imagination of manifestation. What happens in pons, what happens in medulla, what happens in thalamus, what happens in cerebellum, what happens with subcortical area. But a major, more important thing is a basal ganglia. So the three main movement disorder included in Wilson is dystonia, incoordination and tremor. Dysarthria and dysphagia are also common. This is what clinically you look for. This is what a patient comes to you. Okay, because see, all the time when you are reading, have one imagination how this patient will come to me. You know, Wilson's, this is a copper related problem, ATP7B, forget everything. Patient doesn't come with anything like that. He just comes to you with cirrhosis, with hepatitis, or maybe with dystonia, with incoordination or tremor, dysarthria, dysphagia, right? So this kind of things, and these things will be so subtle sometimes, they are commonly ignored. Okay, a kid will be in stress, that's why he's not speaking properly, he's doing some drama, so not eating properly, just unnecessarily telling there's a pain while having food and all. This all thing can happen, and this all happen when you really ask story of Wilson's disease patient. Parents will tell that initially we ignored, we thought it will be like that, and then we do not know, right? The Google doctors and all things screw the cases. So this is an important neurological disorder or the neurological manifestation, and this is the area of focus to do. Okay, dystonia, incoordination, tremor, dysarthria, dysphagia. These are the something which you should keep in mind for the presentation. Psychiatric feature, like neuropsychiatric. So psychiatric feature, half of the patient with neurological disease have history of behavioral disturbance with onset in the 5 years before the diagnosis, right? So the early age psychiatric disorder. Sometimes some people says that this patient has this problem. My mind directly goes to celiac disease, Wilson's disease, lupus, right? It is not common. It is not common to have this kind of psychiatric disease, psychiatric disorder at the early age. If they are there, please rule out organic causes. Okay, so the features are diverse and may include loss of emotional control, the temper tantrums, crying bouts, depression, hyperactivity, loss of sexual inhibition. This all are pointer to your Wilson's disease, right? So this all happens in a young kid, and most of the time it is ignored that that guy gets punishment or something keeps happening. Okay, but no one actually bothers why. And it is something, okay, as an adult we are fucked up and we have done our things, but a kid is most of the time innocent. He won't do anything until unless there is real problem or real trigger. So always try to look into why that happened. Okay, that why will solve so many cases and will save so many lives. The other features of Wilson's includes, we will go to in the full spectrum after this slide. This is what Harrison is describing, so I have kept in order. Okay, what is the common age of presentation? What are neurological manifestations? What are psychiatric manifestations? What are the other manifestations? So sunflower cataract and the Ka fring. This can be asked in your MCQ. So keep there. Copper deposition in the outer rim of the cornea. Repeated spontaneous abortion, most becoming amenorrheic prior to diagnosis. This is a very important thing for your clinical practice. Recurrent or the repeated spontaneous abortion. You think antiphospholipid syndrome, I am sure on that. You are thinking of that. Are you thinking Wilson's? Mostly no. So keep that in mind. It will be helping you. Cholelithiasis and nephrolithiasis occurs with increased frequency. I won't answer why nephrolithiasis and cholelithiasis is common in Wilson's disease. The moment you will open renal tubular acidosis, somewhere you will get Wilson's disease. So see where exactly and why nephrolithiasis. And if you are smart enough, I think you have figured out the answer, which type of RTA and nephrolithiasis here. Some patients have osteoarthritis, particularly of the knee. Again, a young OA. You may have to suspect all this thing. Microscopic hematuria is common, right? So this is so much important thing to know here, that you have a neurological manifestation, you have liver manifestation, you have microscopic hematuria, you have autoimmune hemolytic anemia, like it's Combs negative but hemolytic anemia. Are you making a thought of lupus here? Yes, it can be a good mimic. Liver won't be that much. The movement disorder will not be that much, but it can happen. And someone adds recurrent abortion to that, life is totally screwed up, right? So you have to have a good mind that what can be the differential diagnosis of a almost similar multi-organ syndromes, right? So this is the point: young age, recurrent abortion, movement disorder, liver problem, hemolytic anemia. I think lupus as a rheumatologist as a biased, but if I am not aware of Wilson's disease, I am really going to screw my patient, right? So that is the importance, that you learn mimics and then you make a diagnosis. Once you make a diagnosis, always ask a question: is it really the case? Are you really sure about this? If you really get that answer from inside, go ahead with the treatment. So this is a very good image to show that what are the clinical manifestation of Wilson's disease. This is from Nature Review. So they have divided it in the primary symptom and the potential secondary symptom. So primary symptom is due to direct copper deposition, secondary is more of the deposition and then causing lot of damage there. So if you see the primary neurological symptom, we have already seen movement disorders, speech disturbance, drooling, gait and balance disorder, personality disorder, mood disorder, psychosis and cognitive impairment, right? Ophthalmological, K-fring and the sunflower cataract. Sunflower cataract are really rare. K-fring is common. We will see how common even. Next, going to liver, asymptomatic elevation of liver enzyme, acute hepatitis, acute liver failure, compensated liver cirrhosis, decompensated liver cirrhosis. Anything, full spectrum can come in liver. So that is very important to know for sure. And acute hemolytic anemia, which is Combs negative hemolytic anemia. These are the primary symptoms of the Wilson's disease. Secondary can be glucose intolerance, parathyroid insufficiency, disorder of growth, cardiac arrhythmia, cardiomyopathy, tubular dysfunction, nephrolithiasis. You got the answer already. Amino aciduria, hypercalciuria, and hyperphosphaturia. They can have menstrual irregularity, delayed puberty, gynecomastia, frequent miscarriage, osteoporosis, chondrocalcinosis, osteoarthritis, and joint disease. And they can have hyperpigmentation of leg, anatoderma, xerosis, acanthosis nigricans, subcutaneous lipoma, and dermatomyositis also. So there are a lot of overlap associated when the secondary features are there. And I read something called anatoderma. Please Google that skin lesion, anatoderma. It was classically described with antiphospholipid syndrome. It is also described with Wilson's disease. Now you see how good overlap it is. They are almost associated there. So we have to be quite careful when we deal this kind of disease, right? Mimics are mimics. But see, the things are mimics becomes more mimics when you think too much, when you think like MCQ person. If you take a very honest clinical history and try to make a simple interpretation of diagnosis, you will not be confused much, right? So that is the importance of having a simplistic approach rather than too much of the show off, right? So how do we make diagnosis? And I think now this is the 2-3 pages or the 2-3 slides which are quite important. Otherwise things are fine. You know what is gene, you know what is pathogenesis, you know the clinical spectrum. Now we will come that when you suspect a Wilson's disease, how do you make a diagnosis of that? So what are the available investigation? What are the plus minus of that? That we are going to discuss. So serum ceruloplasmin level should not be used for the definitive diagnosis. Normal in up to 10% of the affected patient, reduced in the 20% of careers even. So it is neither that sensitive nor that specific. It can really not be relied completely for the definite diagnosis. So that's the first investigation you were sending, serum ceruloplasmin, right? KF ring, yeah, this is quite interesting. It's definitively diagnosed only by an ophthalmologist using a slit lamp. So when you tell there is no KF ring and if you're wrong there, it's fine. It's ophthalmologist who use slit lamp can only tell it is there or not. For criteria, for definition. For your clinical case, you have to tell, okay, I looked at the cornea and all. I am sure there is some kind of ring, but I'm not sure whether I can label it KF ring or not. I will take ophthalmologist help. Okay, even the how great a examiner there as a physician, sometime you have to be right, because this is what you are going to do in clinical practice, right? So there we have to be careful. Tell me how many times you have sent patient to ophthalmologist to look for the KF ring. So many times. That's a practice, so respect it, right? Why do we have to show off that no, I only will make a diagnosis? No need. Take your colleague's help and it will be really good for patient. It is present in 99% of patients with neurological or psychiatric disease. This line has crossed so many times in MCQ. So please be aware with this line. Second important point, present only in 30 to 50% patient diagnosed in the hepatic or pre-symptomatic state. Okay, so that is the thing, that liver disease and KF ring may not be there. Chances is just 30 to 50%. Neurological or neuropsychiatric, 99%. That makes things so good. I was thinking lupus, I was thinking some other differential diagnosis of celiac and all with the neuropsychiatric manifestation. No, if KF ring is there, the case is solved, and it should be there because it is present in more than 99% patient. That's a really great clinical finding to remember, right? So any patient with dystonia, any patient with neuropsychiatric feature, any patient with altered behavior, you think it is not fitting, look for the KF ring. If it is there, you have solved that case, right? So it's a very important message to take from KF ring. Third is the urine copper level, more than 100 microgram per 24 hours, invariably in symptomatic patients. So in symptomatic patient, it will be high. If it is not there, you have to doubt your diagnosis. Heterozygotes may have value up to 80 microgram per 24 hours, may require a liver biopsy for definitive diagnosis. But for symptomatic patient, yes, it will support you. Okay, it will support you in making a diagnosis. Mutation in ATP7B is recommended for a definitive diagnosis. How do you do a definitive diagnosis of Wilson's? It's a mutational analysis, ATP7B. Liver biopsy with quantitative copper assay is gold standard, but it's a biopsy, invasive procedure. So take your chance properly. So if there is more than 200 microgram of the copper per gram of dry weight of liver, it is gold standard diagnostic for the Wilson's disease. It's a liver biopsy with quantitative copper assay. A very important thing in MCQ they ask is the microscopic finding of the copper stain. No, not that. It's a quantitative assay which will help. The quantitative assay. Okay, so that is the gold standard for the diagnosis. And this is a very important table which is given in your Harrison, that serum ceruloplasmin usefulness is just a little. KF ring, yes, good, specifically on the neuropsychiatric. Urine copper, yes, better than that. Liver copper, even better than that, but you need a biopsy of that. DNA testing for ATP7B, yes, definitive diagnosis, and haplotype analysis, it is used for sibling only. There it is helpful because if it is there, you have to start treatment from very much starting. So these are the normal value of there, the values in the heterozygous carrier and value in the Wilson's disease. Again, the repeat of fact, the KF ring is present in more than 99% of the neurological feature or neuropsychiatric Wilson, while 30 to 50% of the hepatic presentation, right? So these are the thing, and this is the table I know where it is in my practice. Okay, because this will really help you how you are going to send investigation, what investigation you are going to send and how you are going to interpret it. So we'll just add little more information to this. Serum ceruloplasmin, typical finding is it is decreased in a patient with Wilson's disease compared with the healthy control. We know that. So what is a false negative here? Normal levels in patient with marked hepatic inflammation can be there. Overestimation by immunological assay can happen in pregnancy and on estrogen therapy. It can come false negative. It can be false positive where there is a low level in patient with malabsorption, malnutrition and aceruloplasminemia and in heterozygous individual. That's why serum ceruloplasmin is not truly what you are expecting it to be. Next is 24-hour urine copper. When you order in adult, if it is more than 1.6 micromole or more than 100 microgram per 24 hour, or in child more than 40 microgram, it is significant. It can be false negative when it's an incorrect collection, which is a very common thing, and normal level in children without liver disease, it can be there. Okay, so just neurological disease. It is increase in hepatocellular necrosis, increase in cholestasis, may appear in increase owing to sample contamination also. That's a false positive. Next comes the free copper assay. That's called non-ceruloplasmin bound copper. That's called free copper assay. So which is more than 10 microgram per dl or 1.6 micromole per liter. So that is the value we need to know for that. Hepatic copper by biopsy 250 microgram per gram of dry weight of liver, and KF ring by slit lamp examination can be good. Here we already know absent in up to 50% of patient if hepatic vessels. This is absent in most asymptomatic sibling. So sibling, if you send to ophthalmologist के इसका भी KF ring देख लो, it won't be there. Okay, so that's a very important few simple fact. You cannot make a asymptomatic case diagnosis on KF ring. You cannot do that show off with your juniors that I saw KF ring and I diagnosed Wilson. No, he had symptoms. You saw the symptom, you suspected Wilson, you sent to ophthalmologist, he saw the KF ring, and then the diagnosis was made, right? This is the natural history. You do not disrupt it. If your junior is smart enough, he will screw you. That's a don't bluff, right? It is not required. So this is the two slides I will say which are key learning point from this chapter. How you make a diagnosis of Wilson, what test, what sensitivity, what false positive, what false negative. I think this is bare minimum to know, because diagnosis is something, or diagnostic test is something I do order in patient presence in my OPD. While it comes to treatment, I have enough time to decide. There is nothing emergency in the world. Okay, you have enough time to decide if you are taking care of too much things in your life. That you can see the treatment, you can see the dose, everything can be there. But when you are suspecting something, your pen should know and your brain should know what investigation to be sent, what not to be sent, and how to interpret that. For that, you require really good reading. Okay. For management, it is always you can do once you make a confident diagnosis, right? So we will go further on a diagnostic scoring system. This is not given in Harrison, but it makes lot of sense. I'm not telling you to implement in your practice, but when you are confused or when you are really free in your ward, and if you are suspected your Wilson's, do this scoring. It may help you. So first, they consider the typical clinical sign and symptom, like KF ring is present or absent, neurological symptom if present, severe, mild or absent, serum ceruloplasmin whether it's a normal or 0.1 to 0.2 or less than 0.1, Combs negative hemolytic anemia is present or not. So that's a typical clinical finding, and they get scored like this 20120, something like that. Other tests which include liver copper, urinary copper, mutation analysis. Okay, and along with that you make a combination. An important thing to notice that if liver copper is normal, it gets a -1 point, means it is unlikely you are dealing with Wilson's disease. Total score, if it's 4 or more than that, diagnosis is established. 3, diagnosis is possible. 2 or less than 2, it tells diagnosis is very unlikely, and that makes the scoring very beautiful. That's our, I have done enough workup. Now we won't push beyond. This is done. This is not Wilson. And believe me, you have to fight with so many people once you become gastroenterologist to tell this is not Wilson. And if you have attended the rotation of gastroenterology, you might have seen your consultant fighting with the department that no, it was not Wilson. Why did you label unnecessarily? This happens in India every day. Okay. because everyone suspect Wilson, everyone wants to make that rare diagnosis even though it is not up. Coming to the last two slides on management, and I am pretty sure we are all are waiting for the very last slide, that what is there in that MCQ or clinical practice pulse. Now see, this is one table in Harrison I love because it gives everything quite clear what to do when you have a patient with Wilson's disease, which pharmacotherapy. So when you have an initial hepatic presentation with hepatitis or cirrhosis without decompensation, zinc is your first choice. This is asked very commonly, and forget asking, you have to practice it, right? So we should know. You have a hepatic decompensation disease. If it's a mild, trientrin and zinc. Moderate, trientrin and zinc. Severe, go for hepatic transplantation. When it's an initial neurological or neuropsychiatric feature, you give zinc. You do not talk about the trientine here. You do not talk about the D-penicillamine here. Only zinc. Then you can also think of the tetrathiomolybdate, which is with, they said it is not approved yet, but it has shown really good result in clinical trials, so that also becomes a good option. Maintenance therapy is with zinc, pre-symptomatic is zinc, pediatric is zinc, pregnant is zinc. Zinc everywhere except when you have a decompensated disease, you combine zinc with trientry. That's simple. Otherwise, pregnant, pediatric, whatever, it's a zinc, zinc, and zinc. Why, we will see soon. Okay. So anti-copper therapy in Wilson is lifelong because the disease is lifelong. All pre-symptomatic patients treat prophylactically because disease is close to 100% penetrant. That is the importance. If you get a patient of Wilson's disease, if you do not ask about the sibling, if you do not test the sibling, you are doing harm to your patient, right? So please do that, and that will help you. Pregnant patients should be treated with zinc or trientrin throughout the pregnancy, preferably zinc. Recovery with treatment, liver function and neurological function, what happens? Usually recovers after about a year, while the neurological function takes around 2 years, sometimes 6 months, but sometimes 2 years. So this is all natural history, what you should be knowing about the Wilson's disease, right? What are the treatment options? You have to ask that what exactly it is, neurological, or you have liver involvement, compensated, decompensated. The rule is zinc is there. Trientine will there or not, you decide, right? So that's a very important point to consider. Now the point to take, trientine and penicillamine monitor for the drug toxicity, particularly bone marrow suppression and proteinuria. Okay, so proteinuria is a very important side effect of this drug. Monitor for anti-copper effect of trientine and penicillamine by the free serum copper level assay, which is calculated by subtracting the ceruloplasmin copper from the total serum copper. Okay, so total serum copper minus ceruloplasmin copper equal to free serum copper assay, and that is the test to monitor. With treatment, it should be less than 3.9 or less than 25 microgram per deciliter. And these are the, I won't say important to remember number, but to consider this number matters. Now you go for the zinc treatment. It does not require monitoring of blood or urine for toxicity. Its only significant side effect is the gastric burning or nausea, and 24 urine copper can be used to reflect body loading. Okay, so that is the point, that zinc is quite safe, can give for longer time. Side effects are something which can be easily taken care with the symptomatic therapy. Okay, that's why zinc becomes a quite a choice. So how does this drug works? Okay, so D-penicillamine promotes the urinary excretion of copper, same as the trientine, which promotes the urinary excretion of copper, while the zinc salt blocks the intestinal absorption of copper. It is not coming on cause toxicity further. If it's there, we need to excrete it, so you need trientine and D-penicillamine, either of that, right? So this is how you should decide how you are going, how your drugs work, and how you are going to use it, right? So these are the important tables to take. Now there is a very important MCQ which keeps coming, the Nazar prognostic index or the revised Nazar prognostic index. What are the components of that, and which is the cutoff value of that? So disease severity can be estimated with this Nazar prognostic index, and the score, if it's more than 9, should be considered immediately for liver transplantation. Okay, now how do we score it? We consider value of serum bilirubin, aspartate aminotransferase, and prolongation of PT. Okay, bilirubin, AST, and PT. Normal values are there, and then score 0, 1, 2, 3, 4 depending on the value. Then you combine it. If it's 9 or more than 9, you give or you go for the direct liver transplantation. Okay, if hemolysis is present, serum bilirubin cannot be used as a measure of liver function until the hemolysis subsides, and that's a important thing to consider when you are making this course and all. But this Nazar prognostic index has been asked quite commonly in your MCQ to note for. So this is the last slide, and it really matters in your clinical practice. The age of onset of clinical disease may be considerably younger in India and the Far East. Onset often occurs in children at only 5 or 6 years of age. That's the reason you are not seeing so much of Wilson, right? So we have discussed Wilson's disease starting from genetic, a brief of pathogenesis, then going for the features which are clinical features, then going for the diagnostic workup, how to do it and how to make common sense out of that, then management plan, and then a very important line on this global consideration in India, it is 5 to 6 years of age which matters for the Wilson's disease, right? So we'll conclude our class here. Thank you.